Hello, this is lecture 4 in the Practice of Cardiac Sonography 1 unit. The title of this lecture is An Introduction to Echocardiographic Image Measurement. The contents of this lecture are 1. Echocardiography measurement conventions. 2. Introduction to parasternal measurements. 3. Introduction to apical measurements. And 4. Introduction to subcostal and suprasternal measurements. There are 2 lecture learning outcomes. That is, following this lecture you will be able to 1. Define relevant echocardiographic measurement conventions, and secondly, apply appropriate techniques when measuring 2D, M mode and Doppler images from the 4 standard imaging windows. Once again, the textbook is Essential Echocardiography. Chapters 2 and 4 are the most relevant chapters for this lecture. Another important source of information is available via Views. It is the 2015 recommendations for cardiac chamber quantification by echocardiography in adults, which is a recommendation endorsed by both the American Society of Echocardiography and the European Association of Cardiovascular Imaging. Introduction. Echocardiography is the most commonly used non-invasive cardiac modality because of its unique ability to provide real-time images of the beating heart, combined with its availability and portability. The recommended article I just mentioned, that is available via Views and is entitled Recommendations for Cardiac Chamber Quantification by Echocardiography in Adults, states that the quantification of chamber size and function is the cornerstone of cardiac imaging. Normal values from this paper are part of the Western Sydney University Echocardiographic Reference Values document, which will be referred to often throughout the course and which you as students need to be very familiar with. 1. Measurement conventions. Measurement conventions are designed to promote uniformity and consistency and are meant to prevent variation and inconsistency. Echocardiographic measurement conventions are detailed in Section 2 of the Echocardiography Examination Protocol. Each of the imaging modes, that is 2D, Doppler, etc., have measurement conventions that cardiac sonographers need to observe. 2D measurements. 2D echocardiography is the basis of morphologic and functional assessments of the heart. 2D images provide high-resolution images of cardiac structures and their motion, and enable the measurements of cardiac anatomy and cardiac function. The foundational aspects of developing strong 2D imaging are an essential part of this unit of the course. 2D images should be optimized to provide adequate endocardial definition. Only images with adequate endocardial definition enable the accurate assessment of morphology and motion. As such, it's always worthwhile to take the time to find the optimal imaging window and to optimize the image by adjusting frequency, gains, focus, etc. A well-optimized 2D image that provides adequate endocardial definition enables the identification of the white to black interface, that is, of the tissue to blood interface, and this ensures correct caliper placement or tracing. (2D) measurement conventions. Most 2D measurements are made at two distinct points on the cardiac cycle, that is, at end diastole and at end systole. At end diastole, the chamber volumes are their greatest. When measuring the left ventricle, end diastole can be recognized by the following. 1. By identifying the largest or greatest LV dimension or volume. 2. By identifying the initial mitral valve coaptation. Thirdly, by referring to the ECG and looking for the QRS complex. At end systole, the ventricular volumes are least. End systole can be recognized in the first place by identifying the smallest LV volume or dimension, or then by identifying the point immediately before mitral valve opening, and lastly by looking for the T wave on the ECG. It's very important to remember that mechanical events occur slightly later than electrical events, so end diastolic and end systolic measurements are preferentially made with reference to factors other than the ECG, that is, by identifying the largest dimension for end diastole measurements and the smallest dimension for end systole measurements. For example, the image on the left is frozen just after the onset of the QRS complex. This is the moment in the cardiac cycle when the ventricular volume is greatest. Notice on this image that the mitral valve leaflets have just coapted. The image on the right is frozen just after the T wave. Again, this is the moment when the ventricular volume is smallest. This image also shows the mitral valve just prior to opening. M-mode imaging. M-mode echocardiography complements 2D echocardiography, and measurements are best derived if guided by 2D. M-mode provides high temporal resolution information about the motion and depth relative to the transducer of cardiac structures. M-mode can be used to measure dimensions, though 2D is preferable. For accurate M-mode measurements, correct alignment of the cursor is essential, which, as I mentioned in the last slide, is best if guided by 2D images. The left ventricle, aorta, and left atrium are the structures most often measured by M-mode. When measuring the left ventricle, the cursor is directed perpendicular to the long axis of the LV. When measuring the aorta and the left atrium, the cursor is directed perpendicular to the long axis of the aorta. M-mode measurement conventions. M-mode measurements are made by identifying the interface between structures. When measuring the LV, the 2 points of interest in the cardiac cycle again are end diastole and end systole. These time points can be recognized by observing the size of the ventricle and by secondly referring to the ECG. The image at the bottom of this screen provides an example of how the measurements are made. Doppler imaging. Doppler echocardiography measures blood flow velocities in the heart and great vessels. Hemodynamic assessment is a major part of routine echocardiographic examinations. These non-invasive measurements, that is, measurements derived from Doppler, have replaced many invasive procedures because, if measured correctly, they are very accurate. To ensure accurate Doppler assessment, optimizing its pros and limiting its cons is essential. Accurate Doppler measurements are made by ensuring that, first and most importantly, the ultrasound beam is aligned as near to parallel to the blood flow as possible. Other means of ensuring accurate measurements include adjusting gain settings to ensure an optimal display without excess noise, adjusting the scale and the baseline and sweep speed to identify the maximum velocity, and adjusting the sample volume for pulse wave imaging so the sector size is between 2 and 5 millimeters. Furthermore, for color Doppler, ensuring that the sample volume, the color box, is not too large is also important. Pulse wave Doppler. Pulses of sound are used to measure blood flow at a specific point. That is, the sample volume is placed at the point of interest. Pulse wave has excellent spatial resolution, but it displays limited velocity information. That is, at about 1.6 meters per second, aliasing occurs beyond the Nyquist limit. With pulse wave Doppler, the graph displays velocity information on the y-axis, where flow towards the transducer is displayed above the baseline and flow away conventionally displayed below. Time is displayed on the x-axis. This pulse wave Doppler image displays the velocity of blood flow across the mitral valve. 1. The sample volume has been placed at the mitral valve leaflet tips. 2. Flow towards the transducer is shown as peaks above the baseline, which have been measured at specific points, that is, at the peak velocity. And 3. The sweep speed has been optimized to make these measurements. The sweep speed, as indicated the bottom right of the image, is at 100 millimeters a second. This helps to ensure accuracy. Of course, while acquiring images prior to measurement, the sweep speed need not be at 100 millimeters per second. The pulse wave sample volume should be positioned at the point of interest and made as small as possible. Velocity measurements are made by identifying and tracing along the outer edge of the dense envelope, or by selecting the peak velocity, as indicated by the 2 images at the bottom of this slide. Continuous wave Doppler. As the name suggests, and in contrast to pulse wave Doppler, continuous wave Doppler is the uninterrupted emission of sound that is used to measure blood flow. Continuous wave, or CW Doppler, is very well suited to detecting high velocity flow. Unlike pulse wave Doppler, CW is not restricted by the Nyquist limit, and it can measure very high velocity flow. However, due to the continual emission of ultrasound, continuous wave Doppler cannot provide location information, and so in contrast to pulse wave Doppler, it has poor spatial resolution, as it does not identify information from a specific location. By convention, on the CW graph, the display is as follows. Velocity information is displayed on the y-axis, and like pulse wave, by convention, flow towards the transducer is displayed above the baseline, flow away from the probe below the baseline. Time is displayed on the x-axis. As CW can display high velocity flow, it is used to detect transvalvular gradients and shunt gradients. In both cases, blood flow velocities can exceed 4 or 5 meters per second, and so pulse wave is inadequate to measure these. The image on the left shows the continuous wave Doppler measurement of normal flow across the aortic valve with a peak velocity of about 1.1 meters per second. In contrast, the image on the right shows the CW Doppler measurement across a stenotic aortic valve. In this case, the peak velocity is around 4.6 meters per second. Color Doppler. Color Doppler uses pulsed wave Doppler principles. However, color Doppler imaging involves multiple sample sites along multiple beams. The Doppler shift is measured at each site and displayed in color. Red color shows flow toward the probe. Blue color shows flow away from the probe. An easy acronym to remember is BART. BART. Blue away and red towards. On this slide, the apex of the sector, as always, represents the point from which the ultrasound beam is being transmitted. Red color indicates blood that is flowing towards the transducer. Blue color indicates blood flowing away. And the velocity of flow is also coded according to shades within the scale, where deeper colors indicate lower velocities and lighter colors higher velocities. Color Doppler has multiple uses. These include identifying regurgitant flow at valves, recognizing turbulent flow at obstructions, identifying intracardiac shunts, and aligning the Doppler beam. As color Doppler uses pulse wave Doppler principles, it is also limited in its ability to display high velocity flow. Aliasing occurs if the velocity of flow exceeds the Nyquist limit, although at times this limitation can be utilized, for example in the measurement of regurgitant blood flow. The image on the right of this screen is an indication of this, and we will talk at greater length about this in second semester. Tissue Doppler imaging. Tissue Doppler is a relatively new technique that uses Doppler principles to measure the motion of the myocardium. There is an important distinction to remember. Standard Doppler measurements measure blood flow. Tissue Doppler imaging measures the myocardium, the heart muscle. Tissue Doppler displays the velocity of moving targets. As the velocity of myocardium is significantly lower than blood, the tissue Doppler imaging presets are adjusted to detect low velocities. However, as the amplitude of the myocardium signal is significantly greater than blood, the tissue Doppler presets are adjusted to detect higher amplitudes. Just like other Doppler applications, tissue Doppler is angle dependent. Therefore, the ultrasound beam should be directed parallel to the moving myocardium. Comparing tissue Doppler with the other Doppler methods, tissue Doppler detects the motion of the myocardium. The others detect movement of blood. Myocardial velocities are low. Blood flow velocities are high. The amplitude of myocardial signals are higher than those of blood, however. The images on the screen help reinforce this. The peak velocities on the tissue Doppler image are significantly lower than those on the CW Doppler image. However, the intensity of the tissue Doppler signal appears greater than those on the CW Doppler image. The most common tissue target for tissue Doppler imaging is the mitral annulus. The left ventricular S' measurement, which is acquired by measuring the peak systolic mitral annular velocity, is a marker of left ventricular systolic function. The left ventricular E' and left ventricular A' are acquired in a similar way, but they measure early and late diastolic annular velocities, which are markers of diastolic function. Specifically or especially the LVE', which reflects early myocardial relaxation. Another common target is the tricuspid annulus. Peak systolic tricuspid annular motion, the RVS' measurement, is a marker of RV systolic function. Parasternal measurements. Most linear measurements are made from the parasternal long axis view. In preceding lectures, details of patient positioning, transducer positioning, and transducer alignment for parasternal images were given, so this slide simply serves as a reminder of how to position the patient and the probe when acquiring parasternal images, specifically parasternal long axis images. Image orientation is important to understand. Remember that in the parasternal long axis position, anterior structures are shown at the top of the sector, posterior structures at the bottom, inferior structures at the left, and superior structures at the right of the sector. 2D images should be optimized to provide adequate endocardial definition for accurate measurements. Parasternal long axis linear measurements. Linear measurements are commonly used and a parameter often used to describe left ventricular chamber size. Measurements are made at end diastole and end systole. It's very important to ensure that measurements are perpendicular to the long axis of the left ventricle, that measurements of left ventricular chamber diameter are made at the level of the mitral valve leaflet tips, and that the calipers are positioned at the interface of the myocardium and the chamber, and the myocardium and the pericardium. Essential linear measurements of the left ventricle include the end diastolic septal wall thickness, the LV chamber end diastolic diameter, and the end diastolic posterior wall thickness. The wall thickness measurements enable LV mass to be calculated, which is most accurate if indexed to the patient's body surface area. The left ventricular end systolic diameter and fractional shortening measurements are two other essential linear measurements of the LV. Another important linear measurement from the parasternal long axis view is the measurement of the diameter of the left ventricular outflow tract. This measurement can be made from a more proximal or a more distal point. A proximal measurement is preferable, as it is more likely to assist with stroke volume calculations needed to estimate an aortic valve area. The proximal measurement is made 5 to 10 millimeters from the aortic valve leaflet hinge points. To make the measurement, the maximal left ventricular outflow tract diameter in mid-systole is identified, then measured from the white to black interface of the septum to the anterior mitral valve leaflet, parallel to the plane of the aortic valve. Linear measurements of the ascending aorta are further valuable measurements made from the parasternal long axis view. One important difference that needs to be observed when making these measurements are that, unlike all other 2D measurements, measurements of the ascending aorta are made by observing a leading edge to leading edge technique. Furthermore, oftentimes a higher rib space needs to be used to image and measure the maximal ascending aorta diameter, as per the image on the upper right of this slide. An end systole measurement of the left atrial diameter can also be made from the parasternal long axis view, although left atrial volume measurements are preferable, and these are made from the apical four-chamber view, which will be discussed later. Parasternal long axis M-mode measurements complement but do not replace 2D measurements. M-mode measurements are limited because they measure the heart in one dimension, and it is often difficult to align the cursor perpendicular to the long axis of the LV. Parasternal short axis measurements. The parasternal long axis view is recommended for linear measurements of the left ventricle, left ventricular outflow tract, aorta and left atrium. Parasternal short axis measurements of these diameters are difficult to align with the long axis of the heart. However, the parasternal short axis view is often best for visualizing and measuring the right ventricular outflow tract just underneath the pulmonary valve leaflets, the main pulmonary artery and branch pulmonary arteries. It's important to remember that 2D linear measurements are limited because they are made in a single plane, and therefore they only apply to normal shaped hearts. An obvious example of where linear measurements do not represent the true size of the heart is in the case of a left ventricular aneurysm. As seen on this image, the apex is aneurysmal and only a left ventricular volume measurement will provide an accurate estimate of the LV size. Apical measurements. Patient positioning, transducer positioning and alignment for apical images were described in preceding lectures. This slide serves as a reminder of how to position the patient and the probe when acquiring apical images. Apical four-chamber measurements. Measurement of the left atrial size should be part of all routine echocardiogram examinations. Left atrial size is a biomarker of cardiac function. That is, increasing left atrial size is indicative of cardiac dysfunction. Due to its relative ease, measurement of left atrial volume has become the standard way to measure the left atrial size. Measuring the left atrial volume begins with the apical four-chamber view. Once the view has been optimized, zoom in on the left atrium for improved accuracy of tracing. Trace the inner edge of the blood tissue, that is, the black and white interface. Ensure the measurement is made at end left ventricular systole, when the left atrium is largest. Measuring the left atrial volume then requires an apical two-chamber image. Patient positioning, transducer positioning and alignment for apical two-chamber images were described in preceding lectures and are shown on this slide. Once the apical two-chamber image has been optimized, again zoom in on the left atrium for improved accuracy of tracing. Trace the inner edge of the blood tissue interface. Ensure the measurement is made at end left ventricular systole, when the left atrium is largest, and that the patient's height and weight have been recorded to ensure the volume is indexed to body surface area. The RV focused view. Because of its unique anatomy and position in the thorax, the RV needs to be imaged from multiple planes. Having said that, to measure the size of the RV focused apical four-chamber view is best. Optimizing the RV in this view most often requires lateral movement of the probe. The RV should fill most of the image. When acquiring an RV-focused view, care should be taken to ensure that the LV apex remains at the center of the sector. The LVOT should not be open, and the largest basal RV diameter should be displayed. Subcostal images and subcostal measurements. Patient and probe positioning and alignment for subcostal images have been described in earlier lectures, as per this slide. The subcostal four-chamber view is most often used to image the interatrial septum, as in this view, the septum is close to perpendicular to the ultrasound beam. The subcostal short-axis view is often used to measure the long-axis diameter of the IVC. The maximal diameter, measured proximal to its entrance into the right atrium, and the IVC reactivity provide an indication of right atrial pressure. suprasternal images. Patient and probe positioning once again have been described earlier in this slide, and this simply serves as a reminder. The aortic arch and the descending thoracic aorta can be measured from the suprasternal view as per this image. Normal and abnormal reference values for the measurements described in this lecture can be found in the Western Sydney University Echocardiographic Measurements Reference Values document. It's available via Views. This document uses published values from the American Society of Echocardiography and the European Association of Echocardiography. Examples of where to find some of the values included in this lecture are on page 1 of the document, LV diameter and mass values, LVOT and aorta diameter values. On page 2, RV basal diameter, RV S prime values, IVC diameter values. The application of standard measurements from all 4 imaging windows is an important part of a quality echocardiography examination. In conclusion, measurement conventions and standards promote uniformity. Images should be optimized to ensure accurate measurements. 2D echocardiography provides high-resolution images that enable the measurement of cardiac anatomy and function, and measurements are made at specific points in the cardiac cycle. M-mode measurements complement 2D images and measurements. Doppler imaging enables accurate measurements of hemodynamics and require careful optimization of the pros and cons. The application of standard measurements from all 4 imaging windows is an important part of a quality echocardiography examination. This lecture has included a number of standard echocardiographic measurements. The next lecture will look at further standard measurements and introduce how to interpret them by looking at normal values at greater length. Both lectures cover a considerable amount of material that unites both theory and practice. The lectures will be reinforced and all the measurements will be rehearsed at the next on-campus session in the tutorial sessions. However, it's most important that you rehearse and practice and introduce these measurements into your standard practice at your place of employment.